Welcome everyone. It's my pleasure to have you and our distinguished guest speaker joining our conversation today on antimicrobial stewardship. My name is Mary Helen Ribeiro Pombo, and as a fellow at the Center for Health Policy at Imperial College London, I have the privilege of being the lead for this year's Leading Health Systems Network program. To give you some background, the LHSN is a collaborative international network of healthcare leaders and organizations dedicated to improving health service delivery, based at Imperial College, and working in partnership with the World Innovation Summit for Health. Now, before introducing today's speaker, I'll highlight that our Twitter hashtag for this event is #LHSNwebinar. We invite you to interact with others listening to this webinar and tweet key messages, again by using #LHSNwebinar. With that, I will introduce our esteemed speaker who we're very excited to have joining us here today, Professor Dame Sally Davis. As a world-renowned leading figure in antimicrobial resistance, most of you are probably already quite familiar with her work. As Chief Medical Officer for England, Dame Sally acts as the UK government's principal medical advisor and head of public health directors in local government. She has long advocated for AMR-related policies, speaking at numerous events including the World Health Assembly, the 2016 UN General Assembly, the 2015 G8 Science Ministers Meeting, and the 2015 Global Health Security Initiative. Beyond that, Dame Sally was chair of the 2013 AMR Forum at WISH, and for 3 years was chair to the UN Strategic and Technical Advisory Group on AMR. Dame Sally was also appointed as co-convener of the UN Interagency Coordination Group on Antimicrobial Resistance, set up in response to the AMR declaration made at UNGA in 2016. In today's webinar titled The Global Response to Antimicrobial Resistance and Future Directions for Stewardship, our guests will be discussing the One Health approach to tackling AMR and provide an overview of the progress made in the current UK and international response to this urgent issue. In doing so, she will focus on the importance of stewardship activities across the public, private, and philanthropic sectors. With that, I'll invite Dame Sally to give us her valuable insight on this important topic.
Good morning, everyone. I'm going to spend the next 35 minutes, essentially, going through a set of slides that you will see as I talk. They will be on your screen. They're about antibiotic and antimicrobial resistance and the stewardship of our antimicrobials. But of course, while most deaths across the world at the moment are related to resistance to TB, we are particularly concerned about antibiotics, and it's antibiotic stewardship that is underpinning this discussion. So let me start with a brief timeline of the international response to antimicrobial resistance, because it's been really slow. We started back with Alexander Fleming, the discoverer of penicillin, saying in his Nobel Prize acceptance speech that we should expect to see resistance and deaths related to it. But then we forward to 1950, where there was a joint UN committee starting to it took over 50 years to get resolutions at the World Health Assembly, so in truth, to start the discussion about antibiotics and humans. In 2015, countries across the world signed up to the Sustainable Development Goals. And in human health, we don't talk about the SDGs very much. The SDG 3 is about improving human health. But actually, this is the framework for most of the United Nations and countries' multi-country work going forwards. And what we believe is if we do not address AMR, many of these SDGs are absolutely at risk. Anyway, momentum began to accelerate, and the WHO, the Global Action Plan in 2015, the same year as the Sustainable Development Goals. Not surprising that the only time the Sustainable Development Goals paperwork mentions AMR is in the preamble, the explanation, because we from Britain asked for it there, and there are no metrics, so there are some that are relevant. This Global Action Plan, known as the GAP, was then adopted in the same summer, 2015, by the Food and Agriculture Organization, who look after animals, agriculture and fish farming. And then the Organization for Animal Health, the OIE, who really focus much more in depth on animals, recognizing it was a One Health issue. It wasn't people to accept it was a One Health issue. And what we did not put in at that stage, because we didn't understand it as well as we do now, was actually the impact of antimicrobial production, use, and excretion into the environment, and what we're doing to the environment. So, capital A. I hope I'm unmuted now. I haven't touched it. So what we hadn't recognized was the impact of all of this antibiotic production, use and excretion on the environment. And then finally, we took antimicrobial resistance to the UN General Assembly in 2015, had a high-level meeting. So 193 member states signed up to take action. Clearly, to get there, a lot had happened and a lot of work at national and international level, and now we need to make a difference. If you see this next slide, coming out of that UN General Assembly was an agreement for what are called the tripartite, the WHO, the Food and Agriculture Organization, FAO, and the Animal Organization, OIE, not only to work together, but to provide a secretariat to the interagency coordination group of the UN that was announced in March 2017. So we have on the IAC members of UN agencies and also 15 independent experts from around the world. The meetings are chaired by the WHO Director General, now Tedros, and the Deputy Secretary General of the UN, but the work is led by 3 co-conveners, of which I'm one, and you can see the others circled as well, Professor Yunshi Chen, and Dr. It's in a funny place, they've moved around, Dr. Gyansa and Luderov, who is a pharmacist working in Ghana. We've had a lot of other people working on this, so the G20, a forum create global mechanisms for the pipeline of new antibiotics, and the Germans set up an international AMR R&D hub. Argentina's put AMR on the G20 program. G7 has had AMR as a key theme, and are looking at the commitments they've already made. For us in Europe, the EU has done a fantastic job. It has the best regional AMR plan, One Health of any region, and we're part of a joint action on health-acquired infections and AMR. Through that, we contribute to the joint programming initiative for R&D on AMR, and through the Global Health Security Action Package, which brings 59 countries together, we play a key role from the UK on AMR. So our international partnerships are very important. In addition, in order to get the policies and politics right, we have in New York a group of friends, which is the permanent representatives, the ambassadors to the UN, from UK, Ghana, China, Mexico, and South Africa. these same countries come together through their ministers of health, but led as an alliance of champions, the ministers, by Sweden and ourselves. And clearly, we keep highlighting how if we don't deliver good stewardship and new diagnostics, interventions, vaccines, etc., for AMR, we won't deliver universal health coverage. And I've already highlighted the importance of the environment to all of this. So, with that as a background, clearly there's a lot of activity nationally and globally on promoting stewardship, which is the subject for today. And if you think about this, we've got to make sure that we can antimicrobials, and that relies on both awareness and ownership of the issue. People need to really understand why they shouldn't take antibiotics when they only have a cough or a cold, or they have flu and no bacterial infection. We've done a terrific amount to try and raise awareness. I even wrote a Penguin book on antimicrobial resistance that came out in 2013 and just launched. It's the same book translated into Japanese, and I believe it's also being translated at the moment into Italian, and it's a 2-hour read. It's trying to explain to the public and policymakers and what the issue is. With the aim of increasing the understanding of antimicrobial resistance, WHO earlier this year in January launched a massive open online course called a MOOC on antimicrobial stewardship, and already more than 10,000 people from 100 countries representing all of the WHO regions have enrolled in that course. It's got 14 modules, of course, going from foundational clinical knowledge necessary to use antimicrobials wisely, and how we as clinicians can incorporate this knowledge into our daily work using common clinical scenarios. And you will also know that the WHO runs a number of awareness campaigns, including the important annual World Antibiotic Awareness Week, with World Antibiotic Awareness Day falling on November the 18th every year. And this webinar series that you're enrolled on is another way of increasing understanding. So I really appreciate you joining. The World Health Assembly's resolution, Global Action Plan, or for a global framework for development of combat AMR. This is being developed by the tripartite, led by the WHO. It's a One Health approach, you know, animals, fish, plants, and agriculture, and the environment as well. So it addresses stewardship and is looking also at R&D and, importantly, at access, because the argument goes that at the moment in the low-income countries, more people are dying because they aren't getting the right antibiotics and drugs than of resistance. Fast forward a decade, and that we believe will change, and it is the low and middle income countries that are most at risk of rising AMR resistance and the deaths associated with that. In stewardship, the WHO roadmap proposes that framework covers preservation and the optimal use of antimicrobials across One Health, aiming to harmonise stewardship where we can between the human health, animal, plant and food sectors, taking this access issue into account as well. The UK here, we've been involved heavily in consulting on that draft from the WHO of Development and Stewardship Framework, and we really want to see progress both. Well, we want to see change on the ground, so we need a good document and good activities related to that. I was just told that my voice wasn't coming over well, so we've repositioned the microphone, and I hope that's better Thank you for the feedback. Do feedback if there are other issues I can help with. So one important aspect of stewardship is looking after, is preserving the antibiotics we've already got. And we've got to make sure we've got as broad a selection of antibiotics to choose from. But also, we've got a poor pipeline for new antibiotics. We really have not seen new classes of antibiotics come into routine clinical use since the late 1980s. But to my surprise, I then, over the last year, discovered another worry, which is the unsustainable production and supply of classic old antibiotics that we used in the 60s, 70s, and 80s. And this is because we across the world pay so little for antibiotics that they've been consolidated from lots of factories and companies making them to very few, a handful, and then people just stop making them because they don't see a profit in it. And if we don't have those old antibiotics, it's a serious global problem, limiting our treatment options for common bacterial infections. So this is actually a global access issue, not just an issue for low-income countries. So there is a limited number of factories making TAZ, and the main factory in China burnt down at some point last year. And we in Britain had a real problem looking after patients because of the lack of our standard, though moderately expensive, antibiotic. This is a problem for all of us, and not just a problem for low-income countries. So what can we do to ensure people have access to effective medicine? Part of the biennial review of essential medicines list that the WHO does is to develop this aware categorization. Aware because it's access, watch, and reserve. For access, WHO is recommending that antibiotics in this group be available at all times as treatments for a wide range of common infections. It includes amoxicillin, for instance. And this is the area where we're concerned that there aren't all the old antibiotics available. The watch group has got antibiotics that are recommended as first or second choice treatments for a small number of infections. For example, the use of ciprofloxacin used to treat cystitis should be dramatically reduced so we don't get increasing levels of resistance. And then importantly, that reserve group, the third group, includes antibiotics such as colistin and some cephalosporins that should be considered as last resort options and used only in the most severe circumstances when all other alternatives have failed, such as for life-threatening infections due to multi-drug resistant bacteria. And actually, what person, what human would want colistin except as a last resort, because it is such a nasty medicine to take? We from the UK strongly support the WHO's aware categorization, and we are lobbying for other countries to do the same. But you know, it's not just access that's a problem. There is also the problem of substandard and falsified medicine. And clearly these contribute to the rise in resistance. We've got our own drug regulatory agency from the UK, the Medicines and Healthcare Products Regulatory Agency, the MHRA, working at the moment with the European Medicines Agency to ensure that antimicrobials are licensed appropriately, looking at safety, quality, and timeliness, and setting the statutory information on labels for patients and health professionals as appropriate. We're working under the EU Falsified Medicines Directive, and we include the EU provision for tracking and tracing falsified medicines in humans. And the MHRA are the doing a 3-year leading role for a global communications program against substandard and falsified medicines. And that map that you see at the bottom of this slide shows the members of the communications working group. MHRA is working on a tool for the countries to approach these substandard and falsified medicines, not specifically antibiotics, but there will be scope to focus on antibiotics in the future. So let's just look at what's being done in the animal world to tackle AMR. In November 2016, the OIE, the Organization for Animal Health, published its strategy on antimicrobial resistance and the prevalence of antimicrobials. And their work plan includes activities to support individual member countries in their efforts to implement the standards, prudent use, so preservation, appropriate, prudent use, stewardship, and combating AMR in animals, remembering the country's social, economic, and cultural circumstances. The animal sector is, in general, way behind the human sector in low and middle income countries, with far fewer vets and not the workforce of pharmacists and nurses that we are lucky to have in rich countries and in the human health sector. The OIE work plan also includes activities to disseminate and encourage adoption of recommendations in the list of antimicrobials of veterinary importance, which pushes people to use the similar sort of approach to the WHO of the reserved list drug. They want from OIE to strengthen multilateral support for implementation of standards, we absolutely agree with, and they're collaborating with WHO and FAO to support the development of comprehensive and aligned framework of standards and guidelines across human health, animal health, agriculture, and the food chain. OIE is taking the lead in building a global database on the use of antimicrobial agents in animals. You can see the bar chart on the right from 2014 antibiotic use by or antimicrobial use by regions, showing their use adjusted for animal biomass. And this database gives information on the global situation, use and governance of veterinary antimicrobials, not only in terrestrial animals, but also aquatic, so fish animals and companion animals, which is, of course, the correct name for those animals I would call pets for humans. So what's being done in the food and agriculture area, that of the FAO, to tackle AMR? And their action plan on AMR is guiding worldwide efforts to raise awareness of AMR and help motivate changes in practice, to improve regulations, governance, and improve surveillance of antimicrobials and resistant microbes in both the agriculture and food, so along the whole range of the food chain. Their plan stresses the fundamental ways to address AMR in food and agriculture, ensuring that farm and food systems adhere to best practices for hygiene, biosecurity, animal care and handling. Because if you get all of that right, then there's a much lower need for antimicrobial medicines in the first place, just as vaccinating farmed animals and farmed fish builds their ability naturally to withstand disease and reduces the need for antibiotics and other antimicrobials. Of course, the risks from AMR in agriculture are higher in countries where laws, regulations and monitoring systems are weak, so a priority focus for the FAO is building national capacities in these. And we all know that we need more R&D into alternatives to antimicrobials and antibiotics for food and agriculture, particularly in the area of growth production, as well as in efforts to plug holes in our knowledge regarding the environmental pathways of AMR in food in food and farm waste and excretion farms. So I thought you might find it interesting to see some of the things we've been doing in the UK on human health and antibiotic and antimicrobial stewardship. So this work is led by our public health agency, Public Health England, and I want to thank them for the next few slides. And one of the things they set up, launched in 2014, is this Antibiotic Guardian campaign, which is about increasing the awareness of the issue and acting to stimulate behaviour change. It's there all the year round on their website, and people can just type Antibiotic Guardian or PHE and Antibiotic Guardian into Google and they find it. And as well as some education with little video clips and everything, it's a pledge system. So people feel they've learnt something and then they can take concrete personal and collective action to help keep antibiotics active. By the end of November 2017, 56,630 people had pledged an action to become an antibiotic guardian. So from the public to the specialists, from microbiologists to clinicians to nurses. And many come from the animal field and they're looking at this in the human field. And the most popular include, if anyone in my family is prescribed antibiotics, I will ensure they're taken exactly as prescribed and never shared with others. And another one for families that's popular is, the next time I see an antibiotic prescribed, I'll ask the prescriber about the indication and duration to understand if this is in accordance with local and national guidelines. So that is one programme, and it is reaching a lot of people. And every year during World Antibiotics Awareness Week, we raise awareness of this campaign again. We've also done work with a campaign on television, radio, but also outdoor on billboards, in the press and social media to try and get blanket coverage in regional media and national media to keep our antibiotics working. And I'll show you the little video from this, but when we had a look at our pilot campaign in the West England, results were very high. Awareness cutting through to our target audience of 49% of consumers and 60% of general practitioners. The audience spontaneously recalled the red pill and catchy songs, so the creative work was engaging, and GPs reported being asked to prescribe antibiotics less frequently when they weren't needed. So we think there was a 6-point shift in those. So let me see if I can get this to work. Maybe I can get it to happen.
Wonderful pills, but don't ever think we'll cure all of your ills. So every time you feel a bit under the weather, don't always think that we can make you better. Take us for the wrong thing, that's dangerous to do. When you really need us, we can stop working for you. So please don't end up paying the price. Always take your doctor's advice.
I hope that gave you a break from my voice and entertained you. We want it to be a catchy song that every time we use it, people think about antibiotics. I've got a lot more slides, so I'm going to speed up a bit. We've got something called the eBug campaign. It's available on the web in 23 languages, aimed at children aged 4 to 18, and it's got a lot of endorsements from people who've evaluated it as being really successful. We've worked between Public Health England and our Royal College of General Practice to develop this target antibiotics toolkit, a set of resources helping GPs, primary care clinicians optimize their antibiotic prescribing. and lots of other people have signed up to this now. It's freely available on the Royal College of General Practitioners website, RCGP, if you want to get it, and it's all based on behavioural science. One of the important things in that target toolkit is this treating your infection, and it's the most popular resource in it. It's in 17 languages now, but you can personalize it for a patient, aimed at viral respiratory tract infections, and it addresses patient expectations. And we've now got it in a pictorial leaflet for those with learning difficulties, and there's a similar one for urinary tract infection, both text and pictorial. So that begins to help people understand better what to do. Still on this behavioural theme, to tell you that we're in the second round of doing a letter from myself, Chief Medical Officer, to GPs, randomly selected from the highest prescribing to say you are high prescribers. And I'll just show you on the next slide results. What you can see in red is a letter from me comparing them to their colleagues, reduced prescriptions by 3%, among the top prescribing 20%. So the effect equated to a reduction of 0.83% prescribing reduction. Those letters cost us just over £4,000 for the whole programme and saved £92,000 in prescription costs alone, quite apart from husbanding the resources of the antibiotics. So if you want to see that, you'll find it published in the Lancet in February 2016. Clearly, we're also working on animals here, like humans, through this fairly far, but we have started to make really good progress. And what you see in the top right bar chart is our target of 50 milligrams per kilo of biomass, and how voluntarily the different sectors are bringing that down the use of antibiotics, such that we are lower than our target is early. So that's new. It's interesting, for instance, chickens, that the chicken industry were able to bring down the use of antibiotics by 71%, while raising protein production by 11%. This is good hygiene and biosecurity that helps achieve that. But it is able to be done. And the use in animals of highest priority antibiotics for human health, already low, has fallen further across all classes to below 1% of sales. And colistin was the same as last year, and very low compared with most countries in Europe, and well below the stringent 1 milligram per kilo target recommended by the European Medicines Agency. In October 2017, our Targets Task Force report defined sector-specific targets, which are voluntary, and this is the type of work I just talked about with the chicken. But the common factor in underpinning these strategies is the establishment or maintenance of farm and vet level systems of recording antibiotic usage in all of these. And we've been able to find key hotspots to tackle and to help people. But, you know, we do recognise the dispersed nature of red meat sectors, so generally beef, also makes communication, consultation and agreement challenging. So we've still got further to go. If you look at what we're trying to do from the UK to help abroad, most of this relates to our work from the Fleming Fund, which is a £265 million fund of official development assistance, often ODA. And through this, we have a big program to help support laboratories and surveillance programs in low and middle income countries for AMR and the monitoring of antimicrobial use. But it's One Health. It's not just humans, it's animals and agriculture. And you can see our objectives listed there, and clearly objective 5 advocates the application of data to promote the rational use of antimicrobials for human health, animal health and agriculture, linked straight into stewardship we're talking about today. We recently announced joint funding from the Fleming Fund, the Wellcome Trust and the Gates Foundation, 2 grants, one to collect human data into the global burden of disease, which is published openly on the web, and the other to the Open Data Institute to ensure that we collect data in the same format from industry, which takes me directly into the work they're doing and we're doing. So there is an NGO run out of Amsterdam in the Netherlands called the Access to Medicines Index. And with funding from our government, the Netherlands and Sweden, they've done an Access to Medicines Index on antimicrobial resistance. And this is really important. As you can see, out of 28 antibiotics in late stages of clinical development, only 2 of the companies have in place both access and stewardship plans going forwards. And industry does have a big role to play in stewardship of antimicrobials. So we are chivying industry. Interestingly, 4 companies have moved to decouple antibiotics volume from sales agent bonuses. So I'll pick out GSK as a British company. The bonuses for sales staff are decoupled from sales volume, and that applies globally and 13. Pfizer, Shinogi, and Novartis have got programs in place as well, but there is the gold standard in GSK. So, to time, I'm pleased to say, in summary, what I tried through this webinar to briefly and rapidly take you through is global response to AMR, and then emphasize the importance of stewardship, show you the global initiatives run by WHO, FAO, OIE, as well as our own UK actions to promote stewardship both domestically and abroad. We all know that AMR is an escalating global threat. We discover day in, day out how very complex it is and how, therefore, our response has to be multifaceted. Stewardship is hugely important to preserve the effectiveness of our antimicrobials for human health, but actually to treat sick animals, to ensure that we have an effective bee population going forwards. Do you know that olive trees in Italy are infected by a bacterium? We need effective antibiotics to maintain the health of humans and our planetary health, but we must not let them poison our planet as well. There are lots of things I haven't talked about today, including developing to antibiotics, preventing infections with vaccines, and that holds true not just for humans, but fish farming vaccines are terribly important, and also for animals, as well as WASH, which is making sure that we have clean water, good sanitation and hygiene, and not to forget rapid diagnostics and lots more. So thank you so much for listening and actually for engaging in this issue. Thank you for WISH for putting stewardship of AMR high on its agenda, and let us all go forward and improve matters as we continue. So that brings to the end my presentation, but of course we now have 10 minutes of question and answer from all of you.
Indeed, we do have a few remaining minutes for questions and answers, but first of all, I'd like to thank you, Dame Sally, for providing this rich and high-level overview. I think it's been an incredibly insightful presentation for all of our audience. Now, before opening up the floor for questions, I'd just like to remind you that you can use the chat function by typing in your questions into what looks like a question box in the control panel, or please feel free to use the raise hand function, and you'll be able to pose your questions live. We welcome questions, comments, and your reflections. To get us started, we do have a question from an LHSN member from Asia, which will also speak to other public health providers in the audience, I'm sure. The question is, how do we address the challenge of lack of reinforcement in antibiotic regulations within private healthcare, the private healthcare system?
Thank you. I think it is a challenge when you've got private and public systems, because governments usually regulate the public systems and have much more lax systems for the private. One of the important things that we need across the world is that antibiotics, whether for humans or animals and agriculture, should be by prescription only. Because if they're by prescription only, whether from a doctor or a vet or an agricultural specialist, then you begin to limit them immediately. And it's very interesting how we haven't got that right yet. Even in this country, it was much easier to get antibiotics for animals. And I was in a middle-income country where they had really sorted prescription only for humans, but then we were able to go into a pharmacy and buy a big tub of colistin for only $5. So it just shows that people may focus on the human bit and forget the animal bit. I think that for guidelines, again, you have this problem in nations, and we definitely have it. It's very difficult to impose guidelines on the private sector. So we try and use our inspectorate of hospitals to ensure that standards, which are the ones in the guidelines, are being held, are being used by the private sector. But it remains a problem, because only by regulation can you control the private sector. Over.
Great, thank you for your response. Moving on to our next question, which comes from David Grayson from our LHSN network. The question is, which area should we focus on within a hospital setting for most impact?
Hello, David. Thank you for that question. It, of course, depends on the hospital that you're in. But actually, we know that it's very difficult in a hospital to prejudge both what is the bug that's infecting someone. A, is it a bug? Is it sepsis or infection? B, what is the bug? And then the profile of sensitivities and resistance. So what is very important is if a broad spectrum antibiotic is started, or a cocktail of antibiotics, then at 48 hours, they should be stopped routinely, and digital electronic medical records can help with that. And the right antibiotic, depending on the bacteriology that has come through, started. Because only by doing that do we make sure the patient got what they might need, but we're not overusing them when they don't need them. So that is the very big focus. Ensure that swabs and cultures are taken, and then antibiotics are stopped, and future action is based on the growth of those. This, of course, will become much easier as we move into new eras with rapid diagnostics based even on the gases that different bacteria put off, or on technologies like Oxford Nanopore, which it has developed, but there's still some work to be done before it's routine, but where within 2 hours they can run the whole genome of a bacterium and tell you which resistant genes they've got, so thereby making the diagnosis and the resistant profile. But at this point, growth remains the basis, and stopping the antibiotics routinely and only going forward when you know what to do is the answer. Over.
Thanks again, Dame Sally. We now have a live question being posed by another LHSN member, Patindra, from Apollo Hospital in India.
I would like to know what do we do for bringing about a behavior change in the prescribers for, I'm talking about the physician prescribers, what to do to bring about a behavior change so that they are more acceptable to the antimicrobial stewardship program. Do you have any suggestions?
So I think there will be multiple ways of doing this, and we have a behavioural insight team that advise us, and you will be able to find behavioural economists or social scientists who can help you. So at the system level, payment incentives can work. So we have some things where people, hospitals get extra money if they reduce their antibiotic prescribing, the same in primary care. Education can work. So in primary care, we have primary care GP prescribing advisors who are pharmacists, and they go around GPs looking at their practice and giving them advice. Competition works awfully well with doctors, so transparently showing them data and where they are. And that was one of the examples I gave you that was in the last February 2016, where I wrote a letter to some GPs and said, you're in the top 20% of prescribers. They don't like that. A few wrote back to me and said, well, I've got sicker patients than others, but most of them looked at what they were doing and reduced their prescribing, as we showed, by 3%. So there are a different number of behavioural ways of getting at it. One of the ones I showed you, sheet from that general practice, a target program, treating your infection leaflet. And the reason patients like that, and we have this and they like it, is we did some behavioural social sciences work and found that patients feel validated that they're ill if they're given antibiotics, and they like being able to bring up their work and say, you see, I am ill, I've got antibiotics. So we designed this sheet in order that they could say, I am ill, I've got a different sort of prescription. It's not antibiotics, but it's a behavioural prescription telling me what I've got to do, and I've got to stay at home. And we found that that filled that need for patients, so they were able to say, all right, I won't have an antibiotic. So there are a number of behavioural approaches, and those are the ones we've tried. Over.
Thank you again, Dame Sally, for sharing your experiences on this topic. For those of you who are interested in exploring the topic of antimicrobial stewardship and behavioral change, we do invite you to join the LHSN November webinar, which will be speaking in more depth about how to apply behavioral sciences to antimicrobial stewardship programs. Now, our next question is, what is the first step to initiating an antimicrobial stewardship program within a public health system?
So, of course, if we want to initiate antimicrobial systems, we've got to recognize there's a problem. And the easiest way to get into that is to do an audit, and perhaps do an audit in one hospital and just show the profile of infections and resistance in 1 week, both of their inpatients and the workload that they do for their community and their general practitioners. We actually do this on an annual basis to keep ourselves updated. We do a point prevalence study on 1 day every year across the UK, and we see what infections are being diagnosed in that day and what the resistance profile is, because that gives you a basis for saying we do have antimicrobial resistance. Now, what should be our community prescribing advice? How do we put in place the stewardship? How do we work with the clinicians and the community, the patients, to try and get this right so that antibiotics are given to people who need them, but not when they're not? And bringing in, as I was saying in answer to the first question, you know, stopping broad spectrum antibiotics and cocktails at 48 hours after initiation, unless you've got a diagnosis, is a good way. So it's difficult to do just one thing, but data's a good starting point. Data on volume and type of prescribing, data on types of infections and prevalence of resistance. Over.
Thank you again for that. Now, our last question from the audience comes from Roger Harrison. Roger, please feel free to share your question. You have been unmuted.
Thank you. Thank you for a very insightful presentation. One of my concerns is about the work that's been doing to try and reduce street hawkers and local shops in the low middle income countries, whereas, you know, the availability of antibiotics and all sorts of drugs is sort of on the free market, and people tend to be just given a couple of drugs and they're not really sure what they're actually being given.
So, Roger, I share your concern. Not only do a lot of people not get antibiotics or get antibiotics without prescriptions, so were they needed, is it the right antibiotic, but then they can only afford one day when we know that that could drive resistance, even if it's the right drug, when they need a whole course. And of course, the other side of this, and I brought it up in the talk, is that many of the drugs available in markets are counterfeit and falsified, and that's particularly a problem with the antibiotics. And we can only get at this by strengthening health systems and agriculture systems so that the drugs are good quality and they're given for a full course and the right ones. And that's why the agenda of the World Health Organization and the SDGs I talked about, these Sustainable Development Goals, to develop universal health coverage is essential, because it means making sure that people are getting the right drug at the right time and not just being able to buy them. And so we, through our aid agency, DFID, are supporting health system strengthening across the world in low-income countries with a view to fairness and better health, but also reducing inappropriate antibiotic use and improving antibiotic. But it's not going to happen overnight, and you're right, this is a significant problem. Over.
Thank you.
Now, this does conclude our Q&A session. We're very grateful for all of the interesting questions submitted from our audience today. Before moving on to our closing announcements, Dame Sally, I'd like to invite you to leave our audience with any takeaway messages that you may have.
I wasn't warned about that. So, let me say this is one of the most complex problems in human health. It is as or more complex than global warming, but it could kill far more people much earlier than global warming. So we all need to work on this, you know, our grandparents, ourselves, and our children. But, you know, we can do this. If we all do our little bit, the jigsaw will fit together to make a much better picture for our grandchildren. And let's make sure that the present 700,000 people who die every year of antibiotic resistance is the maximum number, and that by all doing our little bit, that number comes down instead of going up. Thank you.
Well, a very special thanks to you again, Dame Sally, for taking the time to speak with us, and a very warm thanks to our audience for joining us today and for continuing this conversation into the future. Now, recordings of this webinar will be available on our website at www.leadinghealthsystemsnetwork.org. Do please feel free to share this link with your peers. As a reminder, we are on social media, so please visit us on LinkedIn, Twitter, and YouTube. You can access recordings and new webinar announcements on these sites as well. Now, speaking of webinar announcements, we'd also like to invite you to attend our next event, which is a web conference meeting organized by the Global Alliance for Infections in Surgery on the 16th of May. The meeting will be bringing various organizations and clinical professionals from around the world to discuss the optimal use of antibiotics and antifungal agents to treat surgical infections in hospitals. Now, with that, we will close our session, and I wish you a lovely day and hope you'll join us again on the 16th of May for our next event. Until then, bye-bye.